Well, hello everybody. Mike Prevost from MikePrevost.com here, and today's discussion is going to be type 2 diabetes. In fact, this is part of a series I want to do on type 2 diabetes. In this first section, we're going to discuss the etiology or the development of type 2 diabetes, how and why it develops. It's important to understand this background material so that you understand the implications and what we need to do in terms of treating and even reversing type 2 diabetes. So let's get started. Well, because we're discussing a medical condition, our standard disclaimer applies here. None of what I say here should be considered medical advice, and you should consult with your physician if you suspect that you have a medical problem. And definitely talk to your doctor before making any dietary or activity or especially medication type changes. So let's talk about the etiology of diabetes, how and why it develops. And I want to start by discussing what I'm going to call the stressed adipocyte theory of diabetes, type 2 diabetes. An adipocyte is a fat cell, and we're depicting our stressed fat cell here. So it turns out that obesity, especially visceral adiposity or visceral body fat, which is fat around the organs, it's typically belly fat, causes stress to adipocytes or our fat cells. And we're not exactly sure why, but there's some theories that seem to be well supported. And one of the theories is that fat cell mass expands, but that blood vessel mass does not expand to match the fat cell mass. And that leads to a little bit of lack of blood flow to the fat cells and can create hypoxia, which is lack of oxygen, and that causes stress to the fat cells. And the other theory is that there's just a critical size that once adipocytes or fat cells reach a certain size that they become stressed. In any case, when adipocytes are stressed, they release a cytokine, an inflammatory cytokine called TNF-alpha. So TNF-alpha is released, and the TNF-alpha goes to the interacts with the pre-adipocyte, and it causes the pre-adipocyte to release something called a chemoattractant. It's MCP1, so it's monocyte chemoattractant protein 1. And what does this do? Well, it attracts monocytes. A monocyte is an immune system cell, and the monocytes are attracted to the area. They show up and they mature and they become macrophages. All right, and so now we have these macrophages, a bunch of macrophages that are attracted to the area because of adipocyte stress. And when the macrophages show up, they're in inflammatory mode, and they start releasing lots of inflammatory cytokines like interleukin 6 and interleukin 1 beta and more TNF alpha. And in fact, they also release some MCP1. So, what's the whole process? Well, stressed adipocyte releases inflammatory cytokines, which results in immune system cells showing up and releasing lots of inflammatory cytokines. Okay, and these inflammatory cytokines cause whole body systemic inflammation, and that can have lots of downstream consequences that we're going to talk about. Okay, so this is an adipocyte here, or a fat cell, and we're going to start talking a little bit about some impact of those inflammatory cytokines. But let's talk about insulin signaling just a little bit. So right here we have, a notional insulin receptor. So insulin binds to a receptor on the surface of a cell, and when it does, it triggers some signaling. So there's a whole signaling cascade. There's lots of signals that go on intracellularly when insulin binds to that receptor. Okay. Now, there's also a cytokine receptor on these adipocytes, and that cytokine receptor binds inflammatory cytokines. All of these inflammatory cytokines that were being produced by the macrophages that showed up. Now, when the cytokines bind to that cytokine receptor, they cause a release of some transcription factors here, IKKB and JNK. Now, these transcription factors alter gene expression in a way that turns off that insulin signal, okay? So think about this. When the cytokines show up, they turn off the insulin signaling so that when insulin binds, it no longer does what it normally does. And that's insulin resistance. So now we have, plenty of insulin around. Insulin's binding to the insulin receptor, but because of these cytokines and the downstream signaling of the inflammatory cytokines, it's turning off that insulin signal. And so that's how inflammatory cytokines can cause insulin resistance. This is basically insulin resistance in the adipocyte. Let's compare a normal adipocyte to an insulin-resistant adipocyte to look at some of the differences. And we're going to highlight one specific effect here. So here's a normal adipocyte. And in a normal adipocyte, we have insulin binding to an insulin receptor, and that causes some downstream signaling which inhibits lipolysis. Okay, what's lipolysis? Lipolysis is the breakdown of fat. So the way we store fat in an adipocyte is in a form called a triglyceride. And a triglyceride is one molecule of glycerol and 3 fatty acids. And in lipolysis, we break that triglyceride down into glycerol and free fatty acids. So when insulin binds in a normal cell, it turns that process off. And I think a lot of you were familiar with that already, that high insulin tends to turn off fat burning. And that's true in a normal adipocyte. Well, what about in an insulin-resistant adipocyte? What's happening? Well, we said that in insulin resistance, the insulin signal becomes muted. And so in an insulin-resistant adipocyte, the turning off of lipolysis is muted. And so lipolysis tends to stay very active, and it stays on longer than it should. And so what's the result of that? Well, the result of that is that we end up with lots of glycerol and free fatty acids in the bloodstream. Now, you might look at this and say, wait a minute, this is a little bit counterintuitive. Are you saying that insulin resistance equals more fat burning? Well, sort of. It turns out that insulin resistance does inhibit insulin's effect on lipolysis. But what insulin resistance does not inhibit is fat synthesis. So in insulin resistance, we're going to talk later on about we have high insulin levels. It triggers lots of fat synthesis, but it also allows more lipolysis. Now those are competing events going on in the muscle cell. And what does that mean? That means that, and I'm sorry, in the fat cell is both breaking down fats and resynthesizing fats. So you just have a high rate of fat turnover, but it does result in higher levels of circulating free fatty acids in the blood. And that's an important thing to note. This is just an expansion of the slide from a couple of slides ago, and we're going to take this step by step. Looks like a lot of stuff, but hang with me. We'll go step by step on this. So we're going to start with the insulin receptor. So when insulin binds to the insulin receptor here, part of that insulin signaling, and you remember I said it causes all kinds of downstream signaling. Part of that insulin signaling happens through the IRS complex. It's insulin receptor substrate, the IRS complex. So, in technical terms, what happens is when insulin binds, there's a phosphorylase that phosphorylates tyrosine residues on the insulin receptor substrate. So it's a tyrosine kinase. And when the tyrosines are phosphorylated on the IRS, then the IRS is active and it sends out a signal. Okay, so there's an intracellular signal that happens. So insulin binds, the IRS tyrosines get phosphorylated, and the signal happens. The signal's turned on inside of the cell. Well, we know that in insulin resistance, that signal is muted, right? So the signal's turned off. Well, let's move over to these other receptors now. We talked about the cytokine receptor already. We said that the cytokine receptor turns off that insulin signaling. And the way it does that is it causes the phosphorylation of serines on the IRS instead of tyrosines, and that inactivates it. The other thing it does, though, is it just causes the degradation of these IRSs. The cell just gets rid of them, it degrades them. And that reduces the cell's ability to respond to insulin. Well, here's something interesting. There's also a receptor on the cell called a toll-like receptor. And these are receptors for free fatty acids. So when circulating free fatty acids are really high, they bind to this toll-like receptor, and it causes the same effects as cytokines. So elevated free fatty acids amplify that insulin-resistant effect in really all cell types. Now this happens in fat cells, but it also happens in muscle and liver. and your muscle is the main site of clearance of glucose. 75 to 80% of ingested glucose is going to get taken up by muscle cells, and when they become insulin resistant, glucose levels rise. Okay? So we have both the inflammatory cytokines and the free fatty acids both producing insulin resistance in multiple cell types. Now let's look at this other thing down here. This is called a pancreatic beta cell. Now insulin, as you know, insulin brings down blood glucose levels by pushing glucose into the cells. That's what insulin does. Insulin is produced in the pancreatic beta cell. And so this is a pancreatic beta cell here. This is where insulin is produced. We know now, and this is a relatively recent finding, that free fatty acids disrupt the pancreatic beta cells. So when free fatty acid levels are high, it causes lots of stress to these little intracellular organs called mitochondria inside the beta cell. Mitochondria are where energy is produced. It causes mitochondrial toxicity. It also stresses a part of the cell called the endoplasmic reticulum. And the end result of that is a couple of things. One is the pancreatic beta cell is able to produce less insulin, so it can't produce as much insulin. It's worse at sensing glucose levels. So normally the pancreatic beta cell, when it senses high glucose, it pumps out insulin. It gets worse at sensing glucose levels. And the other thing that happens is what's called apoptosis or cell death. The pancreatic beta cells basically start dying at some point. So if you have pancreatic beta cells chronically exposed to these high free fatty acid levels due to insulin resistance, you start to lose the ability to produce insulin, and that happens in later stages of type 2 diabetes. We'll talk about that in a minute, but that's a very important implication. So let's take a look. We'll step back and take a look at the big picture overview here. So it turns out that obesity, especially visceral adiposity, we talked about that. So visceral fat, belly fat, is a triggering factor that can initiate insulin resistance. And you know how much visceral adiposity, that's an individual response. For some people, just a small amount of added visceral adiposity is going to cause insulin resistance because they're very prone. And other people, it's going to take a large amount of extra adiposity to cause it. But it's an individual response. And that leads to insulin resistance. And over time, because of elevated free fatty acids and possibly the inflammatory cytokines and factors we don't know about yet, in time, that's going to lead to beta cell dysfunction. The beta cells will no longer be able to produce as much insulin, and actually beta cell destruction, so apoptosis or beta cell death. And eventually, you know, blood glucose levels reach a threshold that we will diagnose you with type 2 diabetes. That's the full etiology of type 2 diabetes. So let's look at our dominoes again and discuss the development, or how this process plays out over time. This is a very important concept to understand. Okay, so we start off with that obesity, or the expansion of visceral fat, and during that time, you know, because we're creating insulin resistance, the insulin's not working that well, we start to see an increase in insulin production. So right in here, we start to see an increase in insulin production. That increase in insulin production, the higher levels of insulin, has an interesting effect. It keeps fasting glucose levels normal. Our blood glucose levels are normal at this point. And the reason they're normal is the body's producing more and more insulin in order to keep those blood glucose levels normal. So the body's compensating. We actually see an increase in pancreatic beta cell size. So those islets and the pancreas that contain those beta cells actually get bigger at this point, and they produce more insulin. Okay, so there's going to come a point, you know, when we reach impaired glucose tolerance, sort of step 2 in this process, where we start to see impaired glucose control. Glucose levels start to creep up a little bit, and the reason why is because insulin resistance becomes so profound, or insulin's not working, the insulin function gets worse and worse and worse, so much so that even though the pancreas is pumping out more and more insulin, it can't keep up. And because it can't keep up, then blood glucose levels start to rise a little bit. So right in here, we start to see a creeping up of blood glucose levels. Insulin's continuing to increase, but blood glucose is starting to increase a little bit because it can't compensate. And, normally blood glucose levels would be around between 85 and 100 milligrams per deciliter. That'd be a normal level. And here's where we start to see, 105, 110 milligrams per deciliter for fasting blood glucose levels. And that's what we would call impaired glucose tolerance. And that's just because now, the pancreatic beta cells are overwhelmed and they just can't keep up anymore. Now, here's another important point. When we reach early diabetes, it's just a number that's been assigned. You'll see that this process has been going on for a long time, but we just use a threshold value, or what's commonly used as a threshold value of 126 milligrams per deciliter, to say that when your fasting blood glucose reaches that level, we're going to say that's when you have type 2 diabetes. It's somewhat of an arbitrary number, to be honest with you. We could have picked 120 or we could have picked 130, but the number that's normally chosen is 126 milligrams per deciliter. But I think you can see, even long before blood glucose levels started to increase, that the disease was present. Here, when fasting glucose was normal and insulin was high, we had the disease, but we only really call it type 2 diabetes once blood glucose levels finally reach that threshold. Okay. Now, at some point between early diabetes and late diabetes, insulin levels are going to stop increasing and they're going to actually start decreasing. And the reason they're going to start decreasing is because of pancreatic beta cell death. At that point, the pancreas has just been overwhelmed by the increase in free fatty acids and possibly the inflammatory cytokines and other factors that we don't understand yet. But the bottom line is pancreatic beta cells start to die, and their function is greatly suppressed, and so that the body can't produce much insulin at all anymore. Now, at this point, once we hit diabetes, the normal course of treatment is medications, lots of different medications, probably starting with metformin, which restores a bit of insulin sensitivity. When that stops working anymore, generally you'll progress to something like what's called an insulin secretagogue. It's just a drug that causes the pancreatic beta cells to produce more insulin. But, in here, when the pancreatic beta cells start to die, those insulin secreting medications are not going to work anymore because the beta cells can't produce insulin anymore, and plus they're dying. And so that's when we have to go to straight up insulin. And high doses of insulin, because we have a lot of insulin resistance. Even the exogenous insulin we're taking is not going to work that well. We'll have to take high doses because the insulin resistance continues. So it's a pretty grim picture here. But, the good news is there's an opportunity to intervene. And the real important message that you need to take home here, and this is probably the most important thing to take home from this whole presentation and the whole series, is the earlier you catch this, the more reversible it is. And so we have lots of evidence now that this process is reversible. Not only can we slow it down and stop it, but we can reverse it and actually restore insulin sensitivity through some lifestyle modifications that we're going to start talking about in part 2 of this series. But here's another important point, that normally we're diagnosed here after this process has been going on for years and maybe even decades. If we could catch it much, much earlier, we'd have a much better chance of not even getting to this point. By the time we get to early diabetes, there's already been lots and lots of damage done, some of that damage being irreversible. I want to expand on this concept of insulin and glucose levels a little bit. This is also an important concept to understand because it relates to diagnosis, or really, determining when this disease process starts. So let's take a look at this. Let's orient ourselves to the graph first. So on this axis, on the vertical axis, we have insulin and glucose concentration. So basically, in this direction is higher concentration. And on the horizontal axis here, we have the stages of type 2 diabetes as we discussed in the previous slide. So that's just the stages of diabetes. So let's look at one line at a time. So let's start with the blue line, which is insulin. So remember, we said in early early on in this disease process, when we're developing insulin resistance, insulin doesn't work as well, so the pancreatic beta cells have to produce more insulin. And in fact, they hypertrophy and the islets expand so that we have more insulin producing capability. And so that insulin line goes up and up and up. Okay, so that should make sense. We also said that we reach a certain point where, because the pancreatic beta cells have been exposed to inflammatory cytokines and free fatty acids, we reach a certain point where those pancreatic beta cells, the function starts to become severely degraded and they start dying. They start going through apoptosis. And so then insulin production starts to really drop. Okay? And that's at some point in the etiology of diabetes, typically late diabetes. Okay? So let's look at the glucose line, though. The glucose line is maybe a little bit more interesting. You can see that it's not until we hit this phase, impaired glucose tolerance, that blood glucose starts to go up at all. Until then, we clearly have something going on because insulin is increasing, but the measure that we normally look at, the lab value we normally look at to diagnose type 2 diabetes, is completely normal. And it can be completely normal for years. It can be completely normal for years, even decades, while this disease process is going on. So if we're just looking at blood glucose and we're waiting for blood glucose to be elevated, we're going to have to wait a long time, and that disease process will have been happening and causing damage for a long time before we act. So the point is, the disease process starts here, but treatment normally only starts here, after there's been a lot of progression of the disease. Remember, the earlier we intervene and treat, the more reversible it is. So we're going to talk a little bit about how do you know, how do we determine if this disease process is going on, if normally what we look at is fasting blood glucose. Because remember, fasting blood glucose really, it's only elevated, at this point. So if you've gotten this far, you might have a burning question, or you should have a burning question in your brain right now about blood glucose levels and pathology. And that question could be, well, if early on in this disease process, fasting blood glucose levels are normal, do I really have a problem? I mean, if blood glucose is normal, so what? Well, the answer is you could definitely have a problem. And let's discuss it a little bit. So I want to start off with this central figure here. And we discussed this a little bit already. Insulin binds to the insulin receptor. It activates the IRS, which causes some downstream signaling. And this is definitely an oversimplification, but it works for our purposes. Basically, there's two broad signaling pathways that happen downstream. Okay, so there's the PI3 kinase pathway, and that's the pathway that's responsible for glucose clearance or glucose uptake by the cells of the body. Now that process is inhibited in insulin resistance. But this other pathway is not. And so what does that mean? That means as we develop insulin resistance, this second pathway that's stimulated by insulin, it remains robust. In fact, it's overexpressed. And when it's overexpressed, it's atherogenic. And what's atherogenic mean? Atherogenic refers to atherosclerosis, which is vessel disease, specifically vessel disease that causes heart attacks and strokes. Okay, so in the early phase of this disease process, we said that blood glucose levels are normal, but insulin levels are high, and that leads to the overexpression of this pathway. And because we have an overexpression of that pathway, we have a strong atherogenic signal. And this is one of the explanations for why insulin resistance is such a risk for cardiovascular disease. And this process is going on, potentially long before blood glucose levels are elevated. So, let's just look at the pathology just a little bit. And I'm going to be talking about this box over here on the left. So one way to classify the pathology is this. microvessel versus macrovessel damage, and it turns out that elevated blood glucose causes primarily microvessel damage. That's damage to small vessels. And so, for example, one of the consequences of diabetes can be blindness, and part of that pathology is damage to the small blood vessels in the eye. Another is kidney failure, and that's damage to the small, delicate blood vessels in the kidney. That's microvessel damage caused by elevated blood glucose. Well, high insulin, through this mechanism that we just discussed, can cause macrovessel damage. And now we're talking about damage to larger vessels, the vessels that supply the brain and the heart, leading to potentially strokes or cardiovascular disease. And so these effects are happening even without elevated blood glucose levels. So, what's happening early on does matter. It matters a lot. So to reduce the pathology, we need a normalized blood glucose and we need to reduce insulin concentration, both. Okay, don't be freaked out too much by all the information on this particular diagram. We're going to go through it step by step and keep it really simple, and hopefully you'll understand what's going on. So, and if you need to, watch it a couple of times. This is a really important concept, and this is diabetic dyslipidemia. So long before we have elevated blood glucose, we have this going on, and this is going to contribute to our risk for cardiovascular disease very significantly. And when I say dyslipidemia, I mean blood lipids. So I'm talking about cholesterol and triglycerides. And we see a very specific pattern in insulin resistance and diabetes, and we're going to discuss how that pattern arises. So we're going to start with the fat cells out here, the adipocytes. And we already discussed this. We said, that insulin normally turns off lipolysis, right? And in insulin resistance, that effect of insulin turning off lipolysis is inhibited, so we end up with more lipolysis. So we end up with more circulating free fatty acids and glycerol. Because remember, triglycerides are broken down into free fatty acids and glycerol. Now, why is that a problem? Why do we care about elevated free fatty acids and glycerol? Well, because that exposes the liver to higher levels of free fatty acids and glycerol. And so when that happens, the liver takes up those free fatty acids and glycerol. Well, what does the liver do with them? Well, the free fatty acids and glycerol are the building blocks of triglyceride, right? They just came from triglyceride in the adipocytes. And so the liver, when it takes up those building blocks, it resynthesizes the triglycerides. So the liver basically makes fat. So it increases triglyceride synthesis. Well, that's all well and good, but increased fat in the liver is toxic. And so the liver wants to get rid of it. Increased levels of fat in the liver, that's non-alcoholic fatty liver disease. That's cirrhosis of the liver, basically, and that's a bad condition. We don't want it. So the liver prevents that by basically packaging up that fat that it just synthesized and exporting it. And it packages it up into little storage containers. And the storage containers are very specific containers. They're VLDLs, or very low density lipoproteins, right here. That's the VLDL particle. So this VLDL, it's a storage container. It's a protein-based storage container that contains mostly triglycerides with some cholesterol and phospholipids. That's all. So a bunch of triglycerides, some cholesterol, and phospholipids. So let's retrace our steps a little bit. So because we have insulin resistance, we have lipolysis stays on all the time. We end up with an increased level of glycerol and free fatty acids in the blood, which leads to the liver taking up more glycerol and free fatty acids, which it uses to resynthesize the triglycerides. And because it does not want to keep those triglycerides, it's toxic, the liver packages them up in storage vessels called VLDLs. And then it pushes the VLDLs out into the bloodstream. Okay? So now those steps lead to our first consequence, our first dyslipidemia marker. And our first dyslipidemia marker is increased triglycerides. We see an increased blood triglyceride level. Why? Well, it's these VLDLs. The liver's producing lots of triglycerides and it's pushing them out into the bloodstream in those VLDLs, and so blood triglycerides go up. So pretty early on in this type 2 diabetes process, we see an increase in blood triglycerides. That's a common early marker, long before blood glucose levels are elevated in some cases. Okay. Now let's talk about what happens to these VLDLs in the bloodstream. Well, the VLDLs can encounter another lipid storage particle called an HDL, and this is high density lipoprotein. The HDL you might recognize as what's commonly called the good cholesterol, high density lipoprotein, or HDL cholesterol, the good cholesterol, right? Well, the good cholesterol also, it's a storage vessel, and it also stores triglycerides and cholesterol. Now, when an HDL encounters a VLDL in the bloodstream, it does a specific thing through an enzyme called CETP, cholesterol ester transferase protein, CETP. Okay. Now what happens is the HDL meets the VLDL, and through CTP, the HDL is going to take some triglycerides away from the VLDL, and it's going to give some cholesterol to the VLDL. It's a swap, you know. So the HDL says, hey VLDL, give me some of your triglycerides, and I'm going to give you some of my cholesterol. So they have a little bit of a bargain there. So what happens? So let's think about this. The HDL is giving away some of its cholesterol to VLDL. Well, HDL cholesterol is the good cholesterol, right? And if the HDL particle, this HDL storage vessel, is giving away some of its cholesterol, then HDL cholesterol decreases, right? That's our second marker of diabetic dyslipidemia, is a decrease in HDL cholesterol. And it happens through this mechanism, through the HDL storage vessel giving away some of its cholesterol to VLDL. So let's look at what we have so far. So we have an increase in triglycerides and a decrease in HDL. That's a really common pattern in insulin resistance and can happen long before we have a diagnosis of type 2 diabetes, or even before blood glucose levels go up. So that's important. Now this is really bad when this happens, right? Because what can happen is that HDL now that's carrying more triglycerides but doesn't have much cholesterol at all. It's very cholesterol poor, but it's triglyceride rich. It can go to the liver, and it can give that triglyceride right back to the liver through hepatic lipase, okay? And then now we're left with this little remnant, okay? It's a lipid poor HDL, basically, is what it is. And the body doesn't like these hanging around, and so it sends it to the kidney to be degraded. And this greatly drives down our HDL levels. So that's one of the implications of insulin resistance, is driving down HDL, and it's even getting rid of those storage containers. That's not a good thing. All right, so let's look at what else can happen to the VLDL. And this is another really serious issue. So the other thing that can happen to a VLDL is it can encounter an LDL. LDL is low density lipoprotein, and that's the, quote, bad cholesterol, right? HDL, good cholesterol, LDL, bad cholesterol. So when this VLDL that's produced by the liver, when it encounters an LDL, it does the same thing that HDL did. It takes some triglycerides from the VLDL, and it gives the VLDL some cholesterol. And it does that through the same enzyme, CETP. Okay? So it does the same thing. So we end up with this LDL that is full of triglycerides and is pretty cholesterol poor. Now let's pause a minute and think about the implications there. So our bad cholesterol storage vessels are giving away some of their cholesterol. So what does that mean? Well, it means that LDL cholesterol can be normal or even low in insulin-resistant individuals. How about that? Now, so you might say, well, that's good, right? So if LDL concentration is low, that's good. Well, in this case, it's not good at all, and here's why. Because that LDL now that's full of triglycerides can go to that same hepatic lipase and give up some of the triglycerides. Now that LDL storage vessel is very small. It becomes what's called a small, dense LDL. It doesn't have a lot of cholesterol in it. It doesn't have a lot of triglycerides in it, and therefore it's small. The problem with small LDLs is they're not cleared very easily. Normally LDLs are taken back up by the liver, and they're broken up and they're excreted. right? And that's how we keep our cholesterol levels under control. These small, dense particles are much more prone to be trapped in the vessel wall and cause fatty streaks in the vessel that initiates atherosclerosis. They're much more likely to be oxidized or damaged, which greatly enhances their atherosclerotic effects. Okay, so that's a bad deal. So this is interesting now, and this is another important point, that in a lot of cases, in people who are insulin resistant, we see high triglycerides, we see low HDL, but we see normal or maybe even on the low side LDLs. And so lots of times physicians would look at this and say, well, your LDLs are low, so your risk of heart disease has got to be low. We're not too worried about your blood lipids. When in fact they should be very worried about the blood lipids, because though the LDLs might be low, they're being carried in these very atherogenic particles. Okay? And we can detect this with a very specific blood lipid test called an LDLP, which we'll talk about in another part of the series. But it leads to small, dense LDL particles. Bottom line is, though, that if your triglycerides are elevated and your HDLs are low, you might suspect that you have this process going on. And this is an early warning sign of that you're on that train to type 2 diabetes, that you've caught it really early by looking at your triglycerides and HDLs. Okay, so what does diabetic dyslipidemia look like? Well, we talked about it. One is high triglycerides, okay? The other is low HDL. And when you put those together, you can look at the triglyceride to HDL ratio. If that triglyceride to HDL ratio is high, then this whole process is what's happening in your body. Now, what's a normal triglyceride to HDL ratio? Ideally, we want it to be less than 2, using using milligrams per deciliter, or the way it's measured in the United States. We want it to be less than 2. Certainly, if it's over 3, that's getting really high. And we might suspect, if it's over 3, that we've got some insulin resistance going on. Okay. And also what we see, not always, but in lots of cases, is normal LDL. Even though we have a very atherogenic or heart disease promoting blood lipid profile, the LDLs might be normal. So I'm sure you picked up on our theme here, detecting it early to intervene, because again, the earlier you intervene, the more reversible it is, and the less damage you will have sustained. So how do we detect it earlier to intervene? Well, one of the simple early markers that this insulin-resistant type 2 diabetes pathway is occurring is visceral adiposity. I mean, not everybody that has excess visceral adiposity has this process occurring, but the vast majority do. And it's safe to say, if you have some belly fat, that you're probably at some point in that etiology of type 2 diabetes, especially excessive belly fat. So I would maybe suspect that might be the case, and I'd want to be doing a little bit more digging to find out. If you get a standard blood cholesterol test done and your triglyceride to HDL ratio is elevated, I would also suspect that you have insulin resistance, especially if it's greater than 3. Ideally, we want it less than 2, but if it's greater than 3, I would suspect insulin resistance, and I'd want to do some more testing to find out. Now, what's the definitive test? Well, it's one in the middle. It's elevated insulin. Remember, in that timeline that we looked at, elevated insulin is the first thing we see. So, you can detect insulin resistance pretty early on by looking at insulin levels to see if insulin levels are elevated. Now, insulin's not something that's normally measured in an annual physical or a checkup, but if you have, one of these other 2 risk factors that we just discussed, I would want to be asking for insulin labs to be done. Well, there you have it. There's part 1 of our series. I hope you got a little bit better understanding of insulin resistance, and particularly I hope that you got a firm understanding that this process starts pretty early, long before blood glucose levels are elevated and long before we normally diagnose it. And I hope you also take away the fact that we want to detect it early on so that we can intervene early. The earlier we intervene, the more reversible it is and the less damage we have. Okay, so in the next part of this series, we're going to start talking about those interventions. We're going to present a little bit of scientific evidence, and there's some really good news stories in part two. So I hope you tune in for part two. Anyway, I hope you learned something and enjoyed the presentation. Again, if you have questions, just head on over to my site and submit a comment or click the contact me button and send me an email, and I'll try to answer any questions that you might have. And if you enjoyed this presentation, spread the word. Thanks for listening.